Welcome, everyone. We're going to give people a few minutes to join us to get into the Zoom, so we appreciate your patience. We'll be starting in just a few minutes. Welcome, everyone. We will be starting in just a few minutes. We're going to wait for a few more people to join us, and then we'll get started. So thank you for your patience. Welcome, everyone. It's nice to see so many familiar names on the participant list. And thank you for joining us. We're going to give 1 or 2 more minutes more and let a few more people join, and then we'll get started.
Should we start?
Let's do it.
Okay. Welcome everyone to today's webinar on immunization supply chain system design. This is the second part of a 2-part webinar. In last month's Immunization Supply Chain Design Part 1 webinar, we discussed the elements of and process for supply chain design, redesign, and optimization. My name is Greg Roche, and I'm joined by my colleague, Barbara Lamphere, to present this webinar. Barbara, can you introduce yourself?
Hi, I'm Barbara Lamphere, Senior Technical Advisor at JSI. I've been working in supply chain for a little bit more than 30 years, working mostly in capacity building for individuals and organizations, and also doing system design in a number of countries, including Tanzania, Ghana, and Myanmar, and other places.
Okay, great. And I'm Greg Roche, and I've only been in supply chain for about 20 plus years. Not quite as much as Barbara, but I'm also focusing on capacity development, organizational development, and supply chain system design, assessment, and so forth. At any rate, we're happy to have you back with us, or to welcome you for the first time if this is the first time you're attending one of our webinars. We're also very pleased to have a special guest, Cheryl Rudd. She's the Director of Primary Care and Health System Strengthening at the Center for Infectious Disease Research in Zambia, called CIDRS. Cheryl, can you introduce yourself, please, to our audience?
Hi, everyone. Hi, Greg and Barbara. My name is Cheryl, and I've been working to support the Zambian Ministry of Health for over a decade. In the past few years, we've been working on a few different initiatives to improve the national immunization program, and system redesign is one of these initiatives. I'm really happy to be here with you today and share some of our experiences with you all, and I really hope my internet connection stays strong.
Okay, and we hope so as well. We're very glad to have you with us today. So this is the second webinar in our new series, Ensuring a Responsive Immunization Supply Chain. This webinar continues the theme of system design and focuses more on the elements related to redesign and optimization. I would like to also announce that we are adding new webinars to this series in collaboration with Village Reach. Next month, Village Reach will continue the theme of system design with a webinar titled Light Touch Tools for Immunization Supply Chain System Design. You will be receiving additional information about this webinar and other additions to the series in a follow-up email. Please introduce yourselves to each other using the chat function in Zoom. Tell your colleagues your name and where you work. We will leave time for questions at the end of the presentation. If you have a question during the webinar, please use the question answer function by clicking on the Q&A button at the bottom of your screen. Now let's get into today's webinar topic. Let's briefly review first the objectives of the webinar. In this webinar, we will discuss the basic elements that you need to consider when redesigning a supply chain system. This will build off of our previous discussion from last time when we focused on designing a supply chain from scratch. In this webinar, we will get into more details as they relate to redesign or optimization. Our objectives are to describe the relationship between system design and system redesign and optimization, describe supply chain elements and key performance indicators that might be examined during a redesign or optimization activities with a focus on the in-country supply chain. We want to describe potential changes that might be proposed through an immunization supply chain redesign or optimization. We want to describe also the Zambia experience with immunization supply chain optimization, including the purpose, the process, changes, and some benefits and results. So now let's get started.
Let's review what we mean by system design, system redesign, and system optimization, and then see the relationship between them. During the Part 1 webinar, we defined supply chain system design as the process of optimizing the flow of commodities and information and standardizing the related business processes to manage commodities and information. We will redesign or redesign based on the state of our existing system, if we have a system. The objective of the design or redesign is to support the supply chain to achieve the performance desired, ensuring continuous product availability, making the best use of the resources available. This webinar focuses on the redesign aspect. And in this context, we will be looking at the performance of various elements of our existing supply chain, how they are doing in terms of key performance indicators, and how they can be improved with the specific objective of doing the optimization, making our system more efficient and more effective, making the best use of our resources, and addressing the specific objectives for our supply chain. In a way, this will be like identifying what we consider to be the best of our supply chain and all those involved. We'll see what we mean by this later. We would never want to design an inefficient system or one that cannot provide products to the end users. So you can certainly think about maximizing efficiency and effectiveness and reducing risk during the initial design of the system. But oftentimes when setting up an initial supply chain, the primary focus is to get products to the clients and ensure all the needed data is collected and available for decision making, rather than on creating efficiency by reducing inventory levels and streamlining processes, for example. Optimization is particularly applicable at a redesign, since you can then determine what elements can be improved or optimized based on actual experience and actual performance. Going forward, we will think about redesign and optimization as two components of the same activity. We are redesigning to achieve optimization, or we are working towards optimization by doing a redesign.
Here's the process that we saw last time for a supply chain design: scoping, analysis, design, and implementation. We can think about the same types of activities for redesign, but let's update it slightly. For the original design, where there was no existing system, then we called it scoping. For redesign, it is still an examination of the situation, but here it would actually be an assessment of the existing supply chain. At this stage, we would also clearly identify our purpose or purposes for doing the redesign. We would then still do our analysis, and based on our analysis and our purpose, we would do the redesign. And finally, we would implement the redesign. As before, this is a continual process. After a while, we will want to assess again our redesigned system and perhaps make additional changes. As we saw in the last webinar, these are the supply chain elements that we would design during an initial supply chain design. And we would consider similar elements during the redesign. When we examine our performance indicators and evaluate our actual performance, we will be able to identify what needs the most improvement. We would then redesign those elements to make the improvements. And those improvements will help bring us to an optimized system to make it work better. When considering these supply chain elements, we look at the well-known indicators of supply chain performance, any of which could be improved during an optimization redesign. Let's look at some examples of optimization objectives from countries that are undertaking or have undertaken the optimization process.
As we go into the redesign process, as Greg said, we also need to be aware of the purpose of doing the optimization. What are our objectives? What specific objectives do we hope to achieve? This will help us determine what needs to change and where we will focus our efforts in order to achieve that objective or purpose. Here are a few reasons that countries have given for trying to optimize their supply chains. So if you look at this list, to reduce costs, to decentralize or share workload, minimize workload, etc. One reason we may want maybe to reduce costs, but we can think of costs in several ways. Perhaps our aim is to reduce the ongoing operating costs or to increase efficiency while keeping the need for capital investments to a minimum. The two are complementary. For example, I might be able to gain a reduction in overall operating costs, but that might require that I make a large capital investment to purchase equipment or construct warehouses. Or I might choose to make some investments in my system if it will result in significant savings in ongoing operations. Again, the purpose of our optimization will guide us in the kinds of changes or improvements we would want to make or be able to make. If we come back to the idea of what is best for our supply chain, best could be considered to be any of these characteristics. Lowest cost is best, or lowest workload for our service providers is best, or minimize risk to products is best. There could be a variety of these characteristics what would be best for our supply chain. In fact, our final solution may be combinations of these. For example, the lowest cost that also allows for minimal effort by the service providers. Also keep in mind that in your country program, you may be undertaking an optimization activity for reasons other than those shown here. Let's look at just a couple of examples from this list.
Great, thanks. So now let's imagine that we want to decentralize supply chain responsibilities. A lot of countries want to do that. If that is our defined purpose for doing optimization, then one approach might be to introduce another level into the supply chain. While this might have the impact of raising the quantities of products that you need to manage in your system, it could help by putting products closer to the clients. So if the current system is central to district to service delivery point, then we might make it central to region to district and then to service delivery point. We would have to see what kinds of investments we would need in terms of regional level warehouses. If the current system is central to regional to service delivery point, one option might be to remove the regional level and move that down to the districts. In any case, either of these or other changes as well might share the workload more equitably. Let's look at another example. In this situation, we want to reduce the workload of the service delivery providers so that they spend less time on supply chain tasks and spend more time with their clients and without working longer hours each day. If that is our defined purpose for doing optimization, then our optimization might include changing from a pull system to a push system. The service provider would only report, but not spend time doing resupply calculations. If the SDP is picking up from the resupply point, then moving the resupply points closer to the service delivery points, such as changing from region to service delivery point to district to service delivery point, it would save resupply time for the service delivery point staff. Or you could change from a system where service delivery point staff pick up products from the resupplier to a system where the resupplier delivers to the service delivery point. Again, each of these options may require other changes or costs, but if it helps us to achieve our goal of lightening the supply chain workload at the service delivery point, then for us, the benefits would be worth the investment. Let's look at one more example. Let's say we want to minimize the risk to our products. We know that there is risk of damage each time we handle the products. If our aim is to reduce this risk, then we have to reduce the number of times the products are handled. So for example, removing a level in the system. Of course, damage can also come during transport. So we also have to consider the amount of time the products are kept in the trucks while being transported, or even the type of transport that is used. For example, transporting by bicycle or motorcycle could be more risky than transport by truck. After our redesign or optimization, we will want to examine certain supply chain indicators to judge if our optimization activity resulted in the desired improvements. Depending on our reason for optimization, we can look at different indicators and ask ourselves questions. For example, has product availability increased? Are there fewer stockouts? Or are more facilities stocked according to plan? Or has there been a decrease in the number of emergency orders? Have we reduced losses or wastage? Is the supply chain management workload on the service delivery point staff reduced? Have we achieved any desired cost savings, either in transport or warehousing or other aspects of our operations? Has data availability improved?
So now let's turn to the Zambia experience and our guest speaker, Cheryl Rudge. Cheryl, welcome again.
Thanks, Barbara. It's a pleasure to be here.
So we've been talking about some of the aspects and considerations that we take into account when doing a supply chain redesign or for optimization. And I understand that Zambia has recently done this type of activity.
Yes, we have. We started it a few years ago after seeing a conference that was presenting some local data from countries around the area. And we started working on that and now we're implementing in one province just over the last year.
Great. So let's think about and go through your country's experience. We'll look at the process that you used, changes that were implemented, and any results that you have seen.
Sounds great.
Okay. So we said earlier that we need to have a reason and purpose for doing a redesign, and we saw some examples earlier. So why did Zambia decide to do an optimization? What was their aim, or what was their hope? What were they hoping to achieve?
Well, it started out just through some conversations after seeing data presented from some countries at the TechNet conference a few years ago. And we wanted to see overall supply chain improvements. And it really just started with what would we like to see improve? And I think the first thing that we discussed was vaccine availability and accuracy. We wanted to make sure that people weren't overstocking or understocking at the health facility level. Then we also wanted to reduce or hopefully even eliminate stockouts to ensure that vaccines are available at all times. and really at that point of service delivery. We also wanted to improve stock visibility at district and health facilities, where at that point there was really no visibility, so we didn't know what was there. Districts had an electronic registry, but at the health facility level, we had no idea what was taking place. We also wanted to create a higher vaccine quality with consistent management of the cold chain to ensure that the vaccines are actually viable. And I think the last one, and this was discussed, I think really from the districts and the health facility levels, was to increase that trust in the health system by having a reliable supply chain. And that if a mother is traveling with their child to a clinic for an immunization and there are no vaccines, this really hindered her trust in the system.
So I see this slide shows something about the goal for the program.
Yeah, so generally our overall goal is to look at what supply chain improvements we could make to help us achieve the country's objectives for immunization, which you can see here on the screen. And then specifically in terms of supply chain improvement, the Ministry of Health here wanted the immunization supply chain optimization or redesign to really reduce the logistic cost per dose in creating that efficiency, and also take away time that the health facility staff spent on vaccine logistics, which was really taking them out of their health facilities and away from the clinical care they should have been providing.
Okay, all right. Examples that we had seen, purposes that we had seen before in our examples. So perhaps just for context, can you give an overview of the Zambia immunization supply chain structure so everybody attending has an understanding of the structure there?
Of course. So in our current supply chain, we have a standard hierarchy with national level delivering to provinces on a quarterly basis, and then districts coming and picking up from the province once a month, and health facilities picking up from districts each month. We have about 3,000 health facilities across the country right now. So that's 3,000 health facilities on a monthly basis traveling to districts. And while it's typically supposed to operate this way, there are often variances to this. And we've seen this a lot in the last few years where there's been disruptions in financing for health in the country, which has left deficits at all levels. And what normally is supposed to take can vary quite extensively. And we see that this burden often falls on those lower levels and has a negative impact on districts and especially health facilities, where we find that they might be overstocking or hoarding supplies, or it may result in stockouts as they don't have transportation to pick up vaccines.
I think several of those challenges are challenges that many of our programs have faced over the years. So, okay, great. Let's come back and see what options you looked at. But first, let's get a little bit more information on the process you used. Can you tell us about that process and who was involved and what were the major activities and what was the time frame?
Yes, I'd be happy to. Thanks, Barbara. In terms of who was involved, it was really decisions that are made by the Ministry of Health, but it's in consultation with the EPI Technical Working Group. So this working group really consists of ministry along with UN, bilateral, multilaterals, NGOs and nonprofits, even local universities and civil society organizations, anyone that's interested in child health and immunizations. Additionally, Village Reach supported this process with us, providing guidance and lessons from other countries implementing system design, and really guided us along in these initial stages of the system redesign process. And then from a technical perspective, we also worked with Lamasoft, which helped with the supply chain modeling.
Mm-hmm. So it looks like a very strong group with the government at the helm.
Definitely. And that's the way all decision-making really takes place in the country.
Mm-hmm, mm-hmm. So what were the major activities that you undertook?
So I think about it really in 4 different categories: advocacy and seed funding, kind of planting the seed and seeing what we want to do; data and modeling; dissemination and making decisions; and then mobilizing resources. So starting at the beginning, the advocacy and seed funding, as I mentioned very briefly before, it started with the TechNet conference, where we saw results of the impact of system redesign in other countries. And this led to a series of discussions with Village Reach and government to see if there was interest in exploring ways that Zambia could make changes to make their immunization supply chain more efficient or optimized. And from there, it was Village Reach coming to us and working alongside with government and the technical working group, presenting data and exploring options. And then it was us really making that decision at the technical working group level to say, yes, this is what we want to do. We're interested in taking this to the next step. So from there, government, Village Reach, and CIDRS really put together a proposal of saying this is what we want to do, and Village Reach helped us to mobilize funds to start this process of exploration of the system redesign process. And that was, part of that was also to hold a meeting and to really present these ideas to national, province, district, and health facility levels, as well as all EPI partners and stakeholders. And this is where we decided what we wanted to model and what would work in the Zambian context. So after that kind of initial advocacy and making those decisions, we moved on to data and modeling. We had decided not to, while we're only implementing in one province right now, we decided we wanted to do the modeling across the entire country. So that would mean getting data from across the entire country. So we developed an electronic template to collect the data, and essentially over a few months' time, it's, I guess from inception to when we finished the models, it took about 6 months to do the cleaning, then to go back and forth with the models and work with Lamasoft to finalize what would we present during the next phase, which is this disseminate and decide phase. This, again, we had another workshop where we looked at the process, what the results were, looking at, baseline, what are our current practices? And then also, does this work in our context? And I think during that initial meeting of the results, there were some decisions to make some changes to the models. And in the end, government decided they wanted to proceed, but they wanted it to integrate with some other EPI initiatives and not as a standalone system redesign. From there, the next phase took much longer than we anticipated during this resource mobilization process. It took almost 2 years from when we started having this discussion of, yes, this is what we want to do, to developing a collective impact, like multi-partner proposal with government, and then finally getting funds that were released in October of last year.
Mm-hmm. This is quite a long process here.
Yes, it took much longer than I thought, and I mean, I think one of my concerns along that process was losing momentum, from even some of the stakeholders and people that were initially interested in it. When you drag something out for that long of a period of time, it was a concern. But in the end, what we did end up doing, I think, was more of what government wanted, which was important because now it wasn't just one siloed initiative with CIDRS helping lead this process. It was multiple partners really looking for a more holistic package of how we were going to improve EPI. And so while system design was one pillar of this project, it was also looking at strengthening healthcare worker knowledge and skills, improving data quality and visibility and use, and improving demand for immunization services.
So after you received the funding, I know that took a while. What was the process that you used after that?
So the next few months, once we got funds, was really just a set of meetings and kind of following the normal protocols of what government processes take place. And so that starts out with, an inception meeting and looking at everyone that needed to be there from the national, province and district and across different departments. Again, it's not, like I said, system design is one part of that, but we have data, we have pharmacy, we have MCH, we have information officers. So there's a lot of people that are involved in this if we want this to be something that's more sustainable. So this really set the stage for what's going to take place and allowed the different levels of government to really give feedback and input on how we would begin and what they thought would be best. This is also where we mapped out our transportation routes for the province and breaking the provinces into different zones for vaccine deliveries. And that input was really given by the districts themselves on what would work best. Then from there, we did government planning processes, which is really fitting these activities into their annual work plan and looking for ways to incorporate or leverage off of each other's activities. And again, this is all different levels within the districts and the provinces. So not just like one siloed area that's just for vaccine delivery. After that, we did a baseline assessment so that we could really have an understanding of what practices were taking place at the health facility level in all of these areas. And then had a training within each one of the districts for all of the health facilities. So 1-day training in each district for all the people in their health facility to understand what the project was, but also to do refresher trainings on vaccine management, supply chain and logistics, data use, and the tools that are used for EPI. And after that, we started rollout of the whole project.
Okay, great. So we talked earlier about the types of changes that a supply chain may undergo as a result of optimization and redesign process. So can you tell us first what you considered changing in the Zambia immunization supply chain?
Of course. This really goes back to that first meeting when I was talking about, the decision-making and seed funding and what would work here. And I think during this process, there was a number of things that were brought up as ideas that maybe we could do this. And there were a lot of ideas that were also completely thrown out because we're like, this just will not work here. So we really looked at 4 different things, which was changes to vaccine delivery frequency. Right now it was supposed to be on a monthly basis, but what would change if we increase that frequency? And then optimizing transportation through multi-stop routes, and then changes to the hierarchy of the supply chain. I showed you earlier that typical hierarchy of national, province, district to health facility, and what would take place if we made some changes to that. And then finally looking at ignoring administrative boundaries. So this really means if a district has a health facility that is, or a health facility is closer to another district, why do we only need to do that refilling at that district that they're in? So we modeled these different scenarios that were chosen during our workshop to see the impact on the current system. This process gave us results in terms of the impact on the cost per dose, the logistics cost per dose to deliver each of these vaccines down to that health facility level, and also the staff time for logistics. So how much time do health facility staff spend out on vaccine logistics, and what is the implication across these different scenarios? And this really just allowed us to see the different comparisons of these different scenarios and how it impacted these 2 indicators.
Okay,
so the top line there is really our current system, and that the 2 circles there in yellow were the cost per dose and the amount of time health facilities spent on vaccine logistics. And this is in kwacha. Zambian kwacha is about 20 kwacha per dollar. So if we see 2.83 kwacha, it's about 14 cents per dose. And the amount of time was 50 cents or 50 full-time staff per month spent away doing vaccine logistics. And then we saw it just by making a simple change in our existing structure, such as the delivery frequency, now changing it to 2 months. What's the impact on that? What are the savings and how much time do we see is saved for those health facility staff? I think what was important in this process was the feedback received from government and stakeholders on what was and wasn't feasible in our context, and that cost was not the only decision maker for us. And we can see here in this scenario, which is called scenario B, this was the most effective. It was a savings of 11% in our current supply chain and 2.53 kwacha per dose.
Mm-hmm, mm-hmm. So what did you all end up deciding in the end to do?
So I think there's actually 2 answers to that question. One is what we decided on, and now one is what we're implementing. So the recommendation that came out is that we did multi-stop direct delivery from the province to health facilities while still maintaining that buffer stock at districts so that they still had that autonomy and control. And while it might not have been as optimal in terms of cost, it really fit better into our context, and it still meant a savings.
Mm-hmm. Mm-hmm.
So these are the 13 districts of Southern Province where we started implementation this past year. The province was broken into 3 different zones. And the reason those 3 different zones were done is that there was 2 existing provincial hubs that you can see by those 2 stars, one in Livingston and one in Choma. So there was vaccine capacity to deliver to districts from these 2 provincial hubs. But then there was an additional one, and that star is outside of the province. It's in actually Lusaka province. But that hub actually also is closer to some of the districts in Southern Province. So we kind of did a modified way of how we wanted to implement. So we broke the province into three different zones. The first zone consisting of 4 districts who pick up their vaccines in Lusaka province instead of the province that they are located in because of proximity. The second zone, which consists of 5 districts who pick up vaccines from the Choma hub due to proximity. And the third zone also has 4 districts who picks up from the Livingston hub. And that's kind of how it ended up being mapped out because of our cold chain capacity in the province.
Mm-hmm. Mm-hmm. So can you give us some details of how this system will operate?
Of course. And like I said, so based on our initial recommendations and what we thought we were going to do, we've done it, but it's been slightly changed. And I think for a few reasons. We have 3 dedicated vehicles and drivers for the province right now. And on a monthly basis, district pharmacists or MCH coordinators conduct these vaccine deliveries. While the pharmacist is the main person that would be doing this, they are backup. And I think what we're finding is that their integration between those 2 departments is actually really beneficial. The district staff collect from their 3 different provincial hubs, just like I highlighted in the last slide. And they spend about 2 to 3 days per month delivering vaccines using multi-stop routes in their district. And they also ignore boundaries for health facilities that are closer to them. And something that I think is also a bit different than our original plan is that supportive supervision is also done during these visits, but that supportive supervision is beyond logistics. As this is part of another holistic project, it's not just system redesign. We're looking at other things such as demand and data use and other facets of child health. And it's something else that we're trying to do that we saw was being successful just in our first few months of rollout. It was really looking at those health facilities and those districts that were doing well and doing some sort of exchange between them and other places that aren't doing as well. So one district was doing particularly well, and we had a couple that were really floundering. And so having them just go accompany those districts on their routes was really helpful.
Mm-hmm. Mm-hmm. Great. So let's talk a little bit about any results or benefits you've experienced to date and what else you hope to see in the future.
So we've only been really fully rolled out for 6 months of implementation by these results at the end of June this past year. We are in 289 health facilities in 1 province, but we are seeing some positive impacts that you can see here. And I think beyond just seeing some positive impacts is we also can see what's actually going on. We know what's going on there, which is something we did not have. And CIDRs and the National Ministry of Health are providing supportive supervision through different channels during this time, either through accompaniment during deliveries, but also, which has been a little bit less in the last few months due to COVID. We also have WhatsApp groups with regular communication. And on a quarterly basis, we collect key indicator information from health facilities during our vaccine deliveries and have data review meetings in each of these districts to talk about what performance challenges they're having, and also just to review not only the national data, but this programmatic indicators. Mm-hmm. Mm-hmm. And I think what's important in this is that we're seeing districts see some of the benefit for themselves, and I think that will help with our sustainability. I think some other benefits that we're seeing that I did not anticipate from the beginning is the district ownership side of things, and that we actually are seeing districts starting to want to provide their own vehicles and drivers this early on in the project. Like I said, we're only 6 months into full implementation of this, and to see them already taking up some of these costs, I think is a really great indication of having their buy-in. We're also seeing some districts utilize the vaccine deliveries to deliver other essential medicines and do support for other areas. And while we haven't quantified this yet, I think this is something that is important in times of inadequate resources, that we leverage as much off each other and other programs to see how things can work best.
Right. We had a webinar in the last series about managing vaccines with other health supplies and several of the benefits of that. And I see that you're benefiting from that as well in terms of adding other supplies to the vaccine program. So what about any challenges?
Yeah, I mean, we're still facing challenges, and I think we're trying to learn as we go and really get those feedback loops coming from the districts to see how best we can make the improvements. But normal things is late submissions of data, and we're going out to do vaccine deliveries with the districts, but they're not getting the information they need from the health facilities in time. And, just the overall supportive supervision that we need to be providing, such as gaps in knowledge on how to do forecasting or incomplete data from the registers. And so these are things that we're really going to be working on in the coming year to help strengthen. And one other thing was just, again, I mentioned it briefly before, was just that communication across the different district departments and trying to get them to facilitate some more communication among themselves.
So a lot of those challenges really are on some of those softer skills or tools or job support kinds of activities and so forth. Okay, so so for everybody to know that at the end of the presentation, we will share the recording of this presentation, so everybody will have all this information if we haven't been able to address all the challenges and benefits thoroughly here. Cheryl, do you have any final words of wisdom or thoughts you would like to share with our attendees today related to the Zambia experience?
Yes, I think just a few reasons of being kind of excited about, just early on in implementation, how we're seeing things progress is to see what districts are coming up for improvement themselves. And I'm quite excited about that. And then we're going to be rolling Logistimo and electronic supply chain software down to the health facility level. And I think that will also help with some of the data management issues that we have seen in the immunization supply chain. And then also just to work with them to figure out how we can start some of this transition, the earlier the better, and look at how we can support that process and help come up with ideas and solutions. And I think when I think about what I've learned over the past year, and actually probably even starting from the beginning of this process, is about partnership and how much time it can really take. That we really need to get that buy-in from all levels for this to work. And for me, what I think is most important is really to listen on what people want, what will really help, and what fits best into this context.
So thank you very much, Cheryl, for sharing your experience with optimization in Zambia. I think it really shows participants that there can be benefits to investing in an optimization activity, even beyond the supply chain improvements, those kinds of investments.
Yeah, thank you so much. It's been a real pleasure, Barbara.
So we will be sharing this PowerPoint as well as a short document that summarizes the Zambia experience in an email with you following this webinar.
Okay, thanks, and sorry for my miscue on the slides. So this is the end of our webinar. Today, we have described the relationship between system design and system redesign and optimization. We described supply chain elements and key performance indicators that might be examined during a redesign or optimization activity with a focus on the in-country supply chain. We have tried to describe potential changes that might be proposed through an immunization supply chain redesign or optimization. And certainly, thanks to Cheryl and Barbara, we described the Zambia experience with immunization supply chain optimization, including the purpose, the process, changes, and some of the benefits or the results. We have some time before we finish to have some questions that have come in. So let me start with one that actually came in through the chat. And if you have other questions, please put them in the Q&A. But we have a question for Cheryl. What are the impacts of infrastructural constraints such as connectivity and electrical power reliability and so forth on your efforts? Do you have any comment for that, please?
Yes, thanks a lot. I think this is something we've seen quite a bit of things especially when we're talking about obviously viability of vaccines and the cold chain. We have had a huge problem in the last couple of years with more load shedding than we had experienced before. And so we are working on doing mobilization for more solar, but it is a constraint. And when we're talking about implementing the electronic supply chain software down to that health facility level, we have serious power issues. So I think that from the electrical power reliability, I don't think it's really influenced our system redesign process because it doesn't really rely on it. But when we're talking about what improvements we want to optimize and improve for our supply chain, it does. And the infrastructural constraints, I don't know of really any other ones. I think really it's just power and cold chain, and making sure there's those two capacities of things. But when it comes to vaccine deliveries, and again, on a monthly basis, and to that part of it, we haven't faced so many challenges. I hope that answers your question.
Okay, great. Thanks very much, Cheryl. Barbara, do you want to add anything in terms of those kind of constraints from your experience?
I think Cheryl covered it. I mean, I know that, in places where we have, redesigned, such as in Tanzania and other places, some of the considerations, of course, are things like, what do you need to do if you're trying to, say, eliminate a level in a system, and therefore, say, in Tanzania, the zonal hubs now are providing product, and this is not vaccine specific, providing product directly to health facilities, adding things like conveyor belts and other infrastructural things that obviously are investments because of manpower constraints and so forth, you're increasing the workload. If you're eliminating a level, you're increasing the workload at the higher level. So what can you do to make that job easier? And then in the Tanzania situation, they added conveyor belts and improved their picking and packing lines.
Okay, great. Thank you. And this is going to be another question, Cheryl. I think you're gonna be the victim for most of our questions. But there's a specific question on the time that you needed to do the advocacy with the Ministry of Health, with the EPI program, and maybe with other public health officials to introduce the new model.
Yeah, so if we could go back to that slide on what process we followed, that really showed us some of the timelines we specifically went through. So from the advocacy to kind of the point where we started to do the data collection of the models, or for the modeling, it took almost a year. But we also had to mobilize resources for those activities, the data collection, some of the meetings, and that's where we were working very closely with Village Reach. So it took about 12 months. And then after the data collection process, when government finally made the decision, it didn't take very long for them to say, okay, here are the results. This is what we want to do. It took about 6 months. And part of that reason was really this back and forth we were having with them on tweaking some of the models and making sure we had exactly what we want. But the biggest part of it was really the resource mobilization.
Okay, great. The next question again is for the Zambia, and I'll try to find the slide because it's a question on your performance indicators.
Actually, before we go on to that one, while you're looking at that one,
sure.
There was a second part to that question. How do you make sure that the model that you introduce is going to be implemented and has the sustainability? And I think in the Zambia situation, I think Cheryl, you can speak to this, I think, but there seems to be that there is a lot of that embracing of the change by the district was pretty amazing. And I think because it was more of a holistic and integrated kind of change that allowed for more than just the supply chain design to be improved. So can you speak to how you implemented and sustained?
I think there's a few things. And I think, one, I don't want to preempt to say that it has been sustainable yet, since we're only 6 months into it. And so I think we're trying to do everything to make sure that there is that ownership. But I think some of the benefits of this taking a bit longer than we anticipated is that there was a lot of discussion on this, and we did create a lot of momentum. And I really think our process that we followed when we got the money to start rolling out was incredibly important. We had everyone sitting at the table, and while we had ideas of what we thought would be best and how to make these improvements based on the modeling and even the other initiatives that we were working with, we allowed districts autonomy to make decisions on what would work best for them. And again, going to that, even the work plans and what was going to fit into their normal cycles, they got to give the feedback of, this is what we should and shouldn't be doing. And I think now, making sure on a quarterly basis, we go back to them and say, how are things going? What do we need to be doing? How are we going to make improvements? What challenges are you facing? I think that also is really helping with this process.
Okay, great, thanks. And thanks, Barbara, for catching the second part of that question that I missed. So the next question, sorry, and I put the slide up because it's related to the indicators. And so they're asking about the performance indicators seem to show a lot of improvements, except for the proportion of health facilities with adequate stock, which we see a fall from 67 to 49. Any comment on why that fell, or any insights into that?
Yes, it was something where when I was even looking at the data, I'm like, what is going on? This doesn't make sense. And so I talked to one of my colleagues and we delved further into it. Make sure first, is this really what's taking place? And it was. And while full stock availability, there were no stockouts taking place or it had decreased massively. This is during a time where we have COVID going on and there was a lack of resources going for things. So the minimum and the maximum to have the appropriate stock levels that they were supposed to have started to fluctuate. And we saw some hoarding taking place. We saw some that were getting dangerously low. And I think we're gonna watch this indicator very closely and have actually spent time in the field this past month to go see what's going on with that. But it did make sense. And when we talked to the districts about it, we understood where this data was coming from and that it did seem very high, like it did seem very plausible. So yeah, it was also something to me that set off a red flag, but it made sense given our current context.
Yeah, thanks for that. And certainly it's unexpected, but yeah, given the current context, as you say, it's maybe not surprising. There's a comment about technology assisting in improving reporting, so let's hope that will be the case. There's another question. Are there any challenges, or is there a challenge for the immunization staff at the health centers or the district or public health office to run Logistimo? I'm not personally familiar with that one, so Cheryl, again, that comes to you.
Yeah, so we haven't rolled Logistimo out to the health facility level. That's something we're planning. We've gotten additional funds to scale to another province, and part of that will be this Logistimo down to the health facility level. So I can't say yet. We've had some issues even at a district level already, and part of that is because there wasn't funds for regular review of this data. So it's something we're really trying to incorporate into this routine review of everything that's taking place at that district and provincial level. So I think that's something that we're going to have to make sure is just as strengthened at that health facility level during our vaccine deliveries. And I think that's something where we realize vaccine deliveries on a monthly basis to each of these health facilities is an opportunity to strengthen some of these other areas. So that will be our plan for the coming year.
Mm-hmm. In previous webinars, we've presented our experience with establishing data review teams at health facility levels, at district levels, and across teams, across levels, and how effective it is to have just establishing the routine of getting together and reviewing data together to do joint problem solving. And that's had such a positive impact in several countries. And that may, sounds like an opportunity there to do that kind of data review team kind of activity on a routine basis. So.
Okay, perfect. So I think we might have a time for one more question, and I'll choose it because I like it. Is it possible? Yeah, because it comes back to something that you guys were talking about earlier. Is it possible to increase the levels in the supply chain redesign process at a reduced cost? And I would take an initial stab at this question. I'll ask for other inputs from the others, but this comes back to our distinction between operating costs and investment costs. So I think it's possible you make an investment to increase the levels in the supply chain. So let's say you add the regional level, perhaps you're going to see a decrease in the overall operating costs because the costs for the district to deliver to the service delivery points sorry, I'm going to mess up the answer. For the regions to deliver to districts, and then the districts to deliver down to the service delivery points, could actually be less expensive, I'm imagining, could be less expensive than for the regions to deliver directly to all the service delivery points in the region. I'm just imagining that it's theoretically possible, but I don't think you can really reduce all of your costs. You either have to invest some to save in the long term, or you avoid investing and pay more over the long term. I think
And
that
you're gonna, yeah,
without-
and you'll increase inventory holding costs because now you're holding inventory at an additional level in the system. And
that
not
is-
the cost of the product, but cost of storage and the cost of wastage, and the possibility of wastage, adding an additional touch point to the system. So, you know, you have to, in each case, you're going to have to just do that analysis to figure out what are your costs. You could be decreasing the amount of workload, but at the same time increasing those inventory costs.
Yeah.
Okay.
Okay. So thanks again, everyone. Those are great questions. We even had some comments thanking people for your great questions. And thanks to Cheryl and Barbara for addressing some of those questions. So again, just to remind everyone, you'll be receiving a follow-up email with additional resources used in the creation of the webinar. You'll get the link to a recording of this webinar, as well as the first one, the part 1 of the series. And you'll also get an evaluation form to help us improve future webinars in the series. We hope that you'll be able to participate in the next webinar of the series, which we mentioned, Light Touch Tools for Immunization Supply Chain System Design, that will be presented by Village Reach. The next webinar will take place on Tuesday, October 20th at 1300 GMT, should be the same time as this webinar. The registration link for October's webinar will be included in the follow-up email, along with specific information about the webinar and the additional webinars coming up in the series. Again, thanks very much, Cheryl, for sharing the Zambia experience. Thanks, Barbara, for your participation in the facilitation. And thanks to everyone for attending and for your questions and for joining us. Thanks again, everyone, and we wish you continued success in your work.
Thanks, Greg. Bye, everyone.
Thank you, everyone.
Bye.